Hi everyone, welcome.
Welcome. Thank you for attending our webinar tonight. Great.
Lower that other one. So, okay, good. Great. Hi all, thanks. And Dr. Kiltz,
Lisa Stack.
Welcome.
Thank you. Thanks for being patient while we made sure we got the best audio and visual for you. We've been doing these great Q&A webinars to really just bounce through as many questions as we can to give you time. Really, we want to give you time. FaceTime with us and FaceTime with Dr. Kiltz with your attention and your incredible knowledge that we can share with everyone. And of course, we will be giving away a free IVF cycle. If you are the winner, I will be emailing you myself after the webinar. And so you will check your email, and we wish you the best of luck.
All right, great.
Thanks. Let's get started.
Let's get right started some of these questions.
Okay, so first question is, I am starting my IVF cycle next week. Last time I hyperstimmed. What are some suggestions this time to avoid ovarian hyperstimulation?
Well, hyperstimulation, which is excessive number of follicles, and also it's related to high estrogen levels. One of the things that we've been using is adding letrozole to that to keep the estrogen levels low, but also triggering with Lupron. One of the challenges, there are a few people that don't respond to the Lupron trigger, and we have to add a little bit of HCG. Those are the challenges. One is to also add Dostonex, and for sure do not do a fresh transfer. You can continue the antagonist, cetrotide or ganirelix, to try to shut things down, but really it's mostly lowering the dose of the gonadotropins, and the other is coasting. So if we're using if we're using HCG as the trigger, we'll coast, where we'll actually allow the estrogen level to drop before we do the trigger shot, do the retrieval, and then add the Dostonex for 5 days and not do a transfer. But the mainstay has been that we've been using Lupron as the trigger. So if you're using HCG, we want to switch to the Lupron instead of the HCG.
Great, thank you. The next question is, how do you feel about caffeine during an IVF cycle?
I personally do not believe that caffeine is adverse to the process. So I think that excessive amounts of anything, of sodas, of coffee, those can be adverse factors. And so limiting to a few cups of coffee, decaf, if you get the jitters with coffee for sure, but a little bit of coffee, I don't believe, or a little bit of caffeine in the process, I don't think it's harmful at all.
Great, thank you. When preparing to start an IVF cycle, is it important to try to be at a healthy BMI? If so, what diet method do you recommend using that will be the most effective method of weight loss?
Well, so high BMIs and weight loss, and we do know that being overweight is an adverse factor when it comes to conceiving naturally or with any fertility treatments. I personally believe the biggest adverse factor is metabolic syndrome. So that's excessive amounts of sugar consumed, and we're all eating too many sugars. I've been recommending the paleogenic and the ketogenic diets. The ketogenic diet is 75 to 80% fat as your calories as fat, and then 15 to 20% as protein, and then 0 to 5% as carbohydrates. If you're reducing the amounts of carbohydrates that much, it can be a big challenge. I believe if you get rid of pasta, bread, milk, sodas, all those things for sure. If you're mostly eating a little bit of potatoes, they can be also a relatively low factor here, believe it or not. If you're eating, I've got the bacon, eggs, butter, beef, which is basically the ketogenic diet. It's completely opposite. We've seen so many people reduce their metabolic syndrome, lower their glucose levels, and without much weight loss, actually significantly improve their odds of conceiving and reducing miscarriages. If you look up ketogenic diet, it's really very helpful. Good Calories, Bad Calories by Gary Taubes, really helpful. Jimmy Moore's book on keto and cholesterol clarity is helpful, and then Richard Feynman's book on the world turned upside down. We've been also working with Maria Emmerich, who has a great book on ketogenesis and paleogenic diets. I think that's really helpful. And one of the best is dietdoctor.com. Andre Einfeld, who's a family doc from Europe, and he's shared some really great stuff. I find that really helpful.
Yeah.
30 days of the Ketogenic Plan has been really, really helpful. My bias is eliminate kale, broccoli, Brussels sprouts, asparagus. It doesn't make sense, but it's been working. Bacon, eggs, butter, beef, yes, which is the baby diet.
Yes.
Try that out. But as you begin to do this, you'll find that your BMI will reduce, your glucose loads and glucose will go way down. Insulin causes inflammation. Glucose is the most toxic chemical in our bodies, and that's why diabetics have all the problems they have. And because you may not have diabetes yet, because of the high carbohydrate and the low fat that's in the standard American diet, which I call the SAD diet, it really matters to change that up. So try that out. We've got some stuff on our website, but Maria Emmerich I think is really helpful, and dietdoctor.com is really helpful.
Absolutely. Many of our clients who maybe tried out just bacon, eggs, butter, and beef and felt, well, I can't do it, I'm just not going to do anything, we definitely recommend, and many clients have found it helpful to start out with Diet Doctor. It's a little more approachable, I think, and then you can move into the more serious diet once you get your feet wet and see that it isn't so hard and you're going to feel great. Okay, next question.
And when it comes to exercise regarding diet, I recommend walking, light things. The majority of what you're going to gain is going to be in what you consume food-wise. That's the miracle that I've realized. And at 60, I do this food plan. I do not exercise. I'm so amazed at my energy and how my weight stays solid. So try it out.
Absolutely. Next question is, are there any programs available to help offset the high cost of medications for IVF, especially the injectable medications?
The answer is yes, and compassionate care through Serono is there. Look online, throw it out to our support group that there are many clients may have extra medications available. The grant program we have available through New York State, which provides both the fertility and the medications up to a limited amount, although we're asking people who have coverage for their meds to provide those, which allows us to help more patients to have that extra fertility care. So check out, we definitely know that Freedom may have some help through Serono, but they also have other plans through other of the pharmaceutical companies can help. If you don't ask, you don't get. Ask away, and we often have some donated medications that we may be able to help also.
Absolutely. And it doesn't hurt to just give our financial team a call, because they really are our financial gurus. I always say any financial questions, go directly to them, because they really will help you find the best rates and navigate this huge ocean of medications.
But mostly through our support group. Ask around. I mean, we can't say whether you can or can't use it, but it's out there. And if you ask someone, it's always an option.
Absolutely. Next question is, what do you suggest my day be like after a transfer?
What do you do after a transfer? And it's interesting whether it's insemination or intercourse, and what does that embryo need in order to find the most comfortable spot. In general, we kind of feel better if we have a spa day. And that's kind of what I recommend more than anything.
Absolutely.
And we offer massage and acupuncture and facials and just couch potato. Although the studies tell us that it may not matter very much. But running a marathon and going for a jog or a bike ride or heating up, I don't recommend. Light, easy, read a good book, happy, joyous, relaxing, meditation, prayer, hang out with a friend which you enjoy, listen to some music, write some stories, paint, whatever it is, but do something that keeps you de-stressed, calm, and relaxed.
Absolutely. Okay. Next question. I already did wait. This is probably our last chance at IVF due to lack of funds. We have one frozen embryo rated only fair. I was wondering, which medication protocol do you suggest for our best chance? The last frozen IVF, frozen transfer.
Well, so the best, the best, and improving your odds, whether it's that last chance or just the next chance, I always say don't call it your last, because you never know when something may show up that may be valuable for you as a gift. We've been using the Medicated Protocol as our go-to standard, which includes with or without the birth control pill, Lupron overlapping with the birth control pill, or Lupron starting in the luteal phase, combined with a hysteroscopy and an endometrial biopsy in the luteal phase about 5 to 7 days prior to your menstrual cycle, combining that with the food plan, the ketogenic diet, adding intralipids weekly. For many of those that we know have a significant autoimmune disease, it's either thyroid dysfunction, arthritis, dermatitis, where we'll want to add IVIG along with intralipids, and then adding Neupogen sub-Q as has an autoimmune beneficial effect to reduce the natural killer cells and help with implantation. We've been using in the past an intrauterine Neupogen, but we moved to the intrauterine HCG and the sub-Q Neupogen, and then Prograf, which is tacrolimus, which is used to help for patients who are going through organ transplants, and it reduces rejection. We've been adding that along with Lovenox and prednisone and baby aspirin, definitely adding acupuncture or massage. So it's kind of our go-to. We're adding our full implantation enhancement along with the endometrial biopsy and the birth control pill, Lupron, and estrogen overlap. Now, recently we've also added or switched from the oral vaginal esterase to either an intramuscular estrogen or the patch, maybe another form. We've been working with My Egg Bank and another protocol where we eliminate Lupron but use the estradiol valerate shot and doing something different. Interesting enough, it really hasn't been proven that that protocol is really different than a natural or Clomid or letrozole stimulated, but it is important to monitor the process closely, add the implantation enhancement with the intralipids and the Lovenox and the prednisone and the Neupogen if you've had multiple failed or there's obvious implantation immune problems. And I definitely recommend that ketogenic 30-day plan, really important. And certainly connect with me. I'd be glad to review things and make sure that we've made changes, because if you keep on doing the same thing, it's not working. Insanity. And the other is laparoscopy hysteroscopy, looking for endometriosis, intraperitoneal evidence of inflammation, and simply removing that inflammation, I think, is really, really important. And if you think about it, the gut is the primary source for the majority of antigens to get into our bodies, and the gut is the source of most of our problems. And since it's right near the pelvis, the uterus, ovaries, tubes, and also the prostate and the testicles are not far away, all of those things adversely affect the eggs, sperm, and the environment for the embryos and that implantation. And then one other that we've been recently talking about is a 14 to 28 day antibiotic regimen of a combination of doxycycline and Z-Pak or zithromycin, because we know that there are many clients who have a subclinical infection that may require more heavy duty or longer antibiotics to help reduce that subclinical inflammation.
Great, thank you. Next question is, does endometriosis affect the chances of IVF?
There's conflicting evidence, but I definitely believe that there's enough out there, and we've seen plenty of patients where we've laparoscopically removed endometriosis and or treated with 3 to 6 months of Lupron to reduce the inflammatory process, increase the integrins, which are important for that implantation. So the challenge is there are plenty of people out there that have had success with endometriosis, and why it affects some more than others, that's the mystery. It's the same question as why did some people, 10% of people who smoke get lung cancer, 90% don't. We don't understand the correlation exactly why, but definitely endometriosis is a factor. I highly recommend a diagnostic laparoscopy hysteroscopy for almost all infertile women to look for that and reduce their endometriosis and increase their success rates. But since it's a surgical procedure considered invasive, where we do it in our office setting, office surgical center, fully accredited, it's a simple 5 millimeter or 3 millimeter incisions, which we're finding where we can take care of that more simply early on to help increase the success, and whether it's going to be natural, IUI, IVF, donor eggs, or donor embryos, all those things can be improved.
Absolutely. Can a woman's lining be too thick for an embryo to implant?
Likely, yes. And certainly if you have a history of anovulation, oligomenorrhea, PCOS, polycystic ovarian syndrome, many of those patients have excessive estrogen, and linings greater than 12 millimeters are probably getting into that level. We usually recommend a withdrawal cycle and or a hysteroscopy D&C, clean out that, make sure there are no polyps, and then start as a clean slate. And it appears that clean slate, we call it tilling the soil, that endometrial biopsy may help with the stickiness of the uterus, and it may improve the immune status in the uterus and will increase success rates. So in general, the 7 to 12 millimeter lining, and so if you're doing your lining check more than 14 days out and you're getting a thick lining, withdraw in some way with progesterone, Provera, endometrin, quinone, or progesterone in oil, or hysteroscopy D&C, clean things out, and then do the ultrasound lining check 7 days after medications. And then typically we're liking to see 10 to 14 days of meds before you have a 7 to 8 millimeter lining before you're proceeding with a thaw and embryo transfer. So too thick may be an issue, and we're usually saying over 12 millimeters may be that number. But we definitely see some people, no matter what we do, that lining thickens fast, gets right there, and if it's a triple lining, then we think it should be okay.
Great, thank you. What is the success rate of a 3-day frozen embryo transfer for a woman under 35 with no fertility problems?
Well, so day 3 or day 5, we believe that both of them have success, although if you're waiting to blast stage overall, you're going to eliminate a lot of people that never make blasts, and so they're never getting an embryo to transfer, so you really can't equate that. But we're getting in the 40 to 60% range for both day 3s and day 5s, but we're selecting based on the individuals. If they're making really great day 3s and they have more than 4 embryos, we're recommending a blast stage, freeze, thaw, or transfer. But if you're at 4 or fewer, in general, we're recommending a day 3 cleavage stage, freeze, thaw, and transfer for those cases.
Great. Is there a better chance of the IVF cycle working with a fresh or frozen eggs?
Fresh or frozen eggs, we're doing well with both of those. What we're really working towards is taking the fresh eggs, creating embryos to freeze. So now you know you have good quality either cleavage or blast stage embryos. Now you can do the work to prepare the uterus in the best fashion. We're having great success with both frozen eggs and frozen embryos. we're taking a lot more because it's easier to coordinate a frozen embryo with the uterus than it is to try to coordinate that fresh embryo with a recipient stage. And we definitely know that we're working not to transfer embryos in the fresh cycle where you've been stimulated and you've got fresh embryos. We do not believe that the synchronicity of that cycle works as well. We're encouraging more and more freeze-all cycles. A progesterone level, previously we were using a progesterone level of 2 nanograms per milliliter of the day of trigger as the indication to freeze. So if it's 2 or greater, we recommend freezing. We're now lowered it to 1.5, and it's going to get to the stage where we're telling everyone we're going to help make your embryos, freeze those embryos, and then go to the next level. And we believe that that's going to be the best for you, especially those people who have coverage for intercourse or IUI cycles where you're making too many follicles. Now you can do a retrieval, reduce the number of follicles, the number of eggs, do your intercourse IUI cycle, bank some eggs or embryos, and if you don't get pregnant, you have some savings in the cryobank.
Great. Besides the ketogenic diet, are there any supplements or other lifestyle changes that we should implement if we're planning to cycle again in 3 months?
So, fertile fatty foods first. It's been called Dr. Kiltz or CNY Fertility's fad diet, fertile and delivered. I think that's really where we're going with the food plan. Lots of fatty fertile foods first. Now, supplements. There's no evidence that any supplements are necessary, but we know that many of our clients have a lot of inflammation, and vitamin D and CoQ10 really help with that. Fish oil, fat, 3 grams or more of a natural fish oil. If you can't consume the fish or the natural fats from pork or beef, then a good quality fish oil, really important. Fish oil reduces inflammation. So 3 grams. We've been using Theralogics, has some great stuff. There's a lot out there. Nature Time, a local source we have here in Syracuse. CoQ10, fish oil, folic acid, 1 to 2 milligrams a day, seems to also help reducing neural tube defects. I believe all these really have an effect on precursors for enzymes and inflammatory process. Vitamin D. If you're vitamin D deficient, get a little solar energy out there. It'll help, but add some vitamin D to 4,000 units a day can be very helpful. And then DHEA, 25 milligrams 3 times a day, seems to be very important for egg quality and health. And if you have reduced or diminished ovarian reserve, we've been using that as a recommendation. And I know Dr. Gleischer at CHR has really talked about that a lot over the years, and we follow that same, and we've had some really great success. Human growth hormone, HGH, we've been adding that as a priming protocol. So the 30-day ketogenic paleo keto plan, high fat, HGH, along with the supplements, really seems to help the quality of the eggs, the sperm antioxidants, the ketogenic diet, along with the CoQ10, fish oil, folic acid. I think all are valuable. Slow down the exercise. Slow down the really heavy stuff. Meditation, yoga, acupuncture, our support group. Boy, so many of our clients simply say, okay, we are a fertility IVF center, but so many of our clients get pregnant by doing the simple things. And we do believe that that is so important.
Absolutely.
The mind is the first thing you want to use, positive approach. Although negative energy is always part of the flowing to the positive, so you have to have all of it. And so through these challenges, we're seeking out ideas to help improve our options and to get to that next level, de-stress. And at all of our centers, we have acupuncturists and yoga specialists and light therapy, massage, facials in some, And so connect with our team, connect with your own practitioner, and seek those things out. It really is helpful.
Absolutely.
Did I cover that?
You did, absolutely did. So the next client is 35 years old and has mild endo, as well as had 2 cysts removed from her tubes and a polyp. Her husband has morphology issues and a lower count. He had varicocele surgery and count has been improved some. Should they do a fresh or a frozen cycle? So some mild endo, a few cysts and polyps taken care of, and an improved count.
So inflammation in all of us causes sperm morphology, causes dilated veins, and then on the female side, the endometriosis affects the egg quality, implantation site, and if you haven't conceived naturally with that, along with the global approach, then an IUI with either letrozole or a combination of letrozole and low-dose injectables haven't gotten there, then IVF is definitely that next stage. You want to make sure that you're adding the implantation enhancement, and we are really, really moving. It's going to get to the stages that everyone's moving to a freeze-all cycle. And with our $3,900 pricing for a package, which is basically, it doesn't include the monitoring or the medications, but it certainly helps because it includes the freezing and the thawing in those embryos. And that's our current pricing that is much more affordable than anyone else in our nation. You have a full payment plan. And so the freeze-all, I think, is really the way to go in all of this. But there are some people that they're not ready for that. So we're very cognizant of that. We are beginning to move to anyone 35 or under, first cycle, single embryo transfer. And we believe that that's going to be really the way to move with that. And since we're incorporating all those transfers in the $3,900 pricing, it makes it much more affordable. And definitely if you have a high estrogen, high progesterone, a significant hyper response, then you'll really want to do that. And then come back with the Neupogen, the intralipids, the IVIG, the Humira in some cases. We've been sending some of our clients to Markham Fertility in Toronto after measuring NK cells and looking at other immune parameters and looking at LIT therapy. And we've had a number of patients. One of my clients today here, after getting ready for an IVF cycle, did LIT and IVIG, conceived naturally, and she's now 27 weeks and doing really fantastic. But we're monitoring the NK cells with the Beer Center, but we are a reproductive immunology center where we are cognizant of that's probably the most important part of everything we're talking about. All human diseases are really, the cause is the immune system, and I believe it's the diet. And if we can get rid of so many of the carbs and add fat, healthy fat, all right, coconut oil, all right, but it's beef fat, pork fat, butter fat, amazing changes.
Great, thank you. The next client is an out-of-town client looking forward to an IVF cycle. Will she be given a timeline to follow with regards to taking the medications leading to the point of insemination or transfer would be? So
definitely we have a calendar set up that we put the whole thing together, make sure that you understand that it is a series of appointments and medication protocols that we want to make sure that you understand it fully. But the eIVF and through the portal, you get those instructions. If there's any questions, we want to hear from you and make sure that you get that properly.
Great. How does a priming cycle improve cycle outcomes?
So the priming cycle, and I learned this from a friend from Montreal, Dr. Faruqi, who works with us and is satelliting patients through Canada. A good friend of his from Spain had been using human growth hormone for 30 days. So the 30-day prime, previously we were using estrogen for 7 days before the cycle. And I believe at least a 30-day prime. And it's basically how do we improve and reduce the inflammatory reactions? How do we help the natural growth factors in our body improve the environment for both the eggs and the endometrium and the pelvis.
Yes.
Just kind of imagine this pelvis that is just being bathed with the adverse immune function in our bodies, or the stressors of excessive cortisol and epinephrine, the electrical adverse factors. So anything for at least 30 days. It may be longer for some. That's the minimum I've been recommending, the 30-day prime, where we've been using a combination of the supplements, the food plan, the keto plan, the human growth hormone, and it may be with or without even low-dose Nuprigen, making sure you're doing the weekly intralipids, adding an IVIG dose. We've been using the Humira also as a factor to this, and the Tacrolimus to that. So we think the 30 days today is our best approach. Get into our yoga and support groups and acupuncture, really a favorable. We're seeing tremendous success, and really so many of our clients that are getting ready for IUI or IVF are conceiving naturally because we're using a global or a blanket approach, which I think is really just the factor that's so important for all of us.
That's great. What are the maximum amount of embryos usually transferred?
It's amazing how we've all changed over the last several years. 2 embryos is really our formulated maximum. Under some rare circumstances, over 42, it may be up to 3 embryos. If they're PGS tested, then 2 is back to that max, and it may get to that time where really we're working through that PGS single embryo tested is going to be the one. But currently, the 2 embryos for 1 embryo under 35, 2 embryos 35 to 40, and certain circumstances it may be up to 3 embryos. But that's really where we're limited, because our job today is really to enhance your success and maximize singleton pregnancies.
Great. Is it better to start a fresh IVF cycle or to go with the day 3 frozen embryo transfer for a woman under 35 who went through 2 failed IUIs and 1 failed IVF?
So repeat that question for me.
So is it better to start a fresh IVF cycle or to go with the day 3 frozen transfer if you've under 35 and had 2 failed IUIs and a failed IVF?
So if you did a fresh transfer and you have a frozen, the question is it better to go to another fresh stimulation or to use the frozens? Well, since frozen transfers seem to be doing so much better, and we're working to eliminate fresh altogether. It's coming, isn't there yet. So I would recommend the frozen embryo transfer. Now, banking cycles matter. I mean, if you get pregnant and you got to wait another year before you can do another cycle, it may be reasonable to begin to think about banking embryos. And we're beginning to recommend for women under 35 who want to bank eggs because they're not ready to reproduce, don't have a partner, or for whatever reason, begin to think about banking eggs or embryos while you're younger and while you're preparing your body and you're not ready yet. So one is, I'd recommend the frozen embryo transfer, whether it's a cleavage stage or a blast stage. And sometimes we might have a bunch of cleavage stage where we elect to thaw them and take them to blast. We might even elect to thaw them, blast, biopsy, refreeze. And we even have some cases where we'll take frozen blasts, thaw them, biopsy them, refreeze them, get the information on whether they're euploid or aneuploid. Although I'm not a big proponent of biopsy embryos and PGS because there is some questionable evidence out there, but really it's a discussion that you need to have with your doctor, your practitioner, to help guide you through that. I have one of my friends who had PGS tested abnormal embryos and retested them and found some normal embryos within those. So it's not without some mistakes that's not 100% accurate. So keep that in mind.
Great. Are there any ways to improve response to the stimulation medications?
So improving response, one is reduce the inflammation in your body. Acupuncture, yoga, meditation, the DHEA, the human growth hormone, PrEP, a combination of Neupogen, HGH in the stem, along with a higher mixed dose of gonal menopur, follistim menopur, or gonal follistim with an HCG, and we're going up to, and the 300 is the standard dose, the 150 is low dose, and then the high dose is 450 to 600 in that. And so be more aggressive at times in order to get that. We've had 3 eggs and 1 embryo and 1 baby, and so what's too few? Well, if you don't do a retrieval and you cancel, you lost the opportunity, you don't know. If you eliminate all of those, you're going to significantly increase your odds of success for fertility centers numbers. So if we just eliminate those we believe have the lower success rate, we're going to keep our numbers up high if we're working for our numbers. But if we're working for your numbers and your success, we're going to give you the opportunity to take that chance and recognize that it may be lower, but it's not a zero. And we've seen so many people conceive when they were given an opportunity rather than eliminated because they don't meet certain criteria. And we've had low AMHs deliver a baby and high AMHs not get pregnant nor deliver a baby. So I think it is important to look at higher dosing, priming protocol, and de-stressing.
Absolutely. What happens if the day of egg retrieval is supposed to happen on the weekend when the office is closed?
We are not closed on the office on the weekends. We have found very successfully that Sunday off and doing retrievals either Saturday or Monday has worked really well. We've been doing that for 20 years and found that it offers great success.
Absolutely.
If we've found in the past, if we can take a hyperstimulated patient and coast them, that means they have great follicles already, and wait for their estrogen to drop and then trigger them at our leisure when we think they're ready, we still get great eggs and embryos. That we have a lot of flexibility in this. So it's worked with 6-day-a-week retrievals and transfers at CNY.
Absolutely.
So we found that, again, it works great.
Thank you. What foods do you suggest to eat while on metformin?
Okay, so I've found a new turnaround food plan that I thought was completely crazy, the Ketogenic Diet, all right? So if you're on metformin, that means you likely have metabolic syndrome. I believe almost everyone in America and around the world has metabolic syndrome, or PCOS, male or female. And by increasing the fats, bacon, eggs, butter, beef, and reducing all carbs to the 0 carb, hard as can be, but once you've done it, you've eliminated your addiction. The body feels great. It's no longer addicted to that stuff. The other is if you're going to consume the carbs, you do it either once a day or 12 hours apart. We are not grazing animals that were meant to eat food 5 or 6 times a day and snack in between. That's bad for us. I'm convinced that the gut, and if you read, again, Gary Taubes and Richard Feynman and Maria Emmerich, and there's so many books that I'm finding, wow, that doesn't make sense. You do it, you'll be amazed. A little bit of potatoes, sweet potatoes, maybe okay. And Maria has some really great stuff that I think if you go to Maria Emmerich's stuff, she has a great book, Keto Adaptive. You'll find some really great stuff. I learned initially with William Davis and David Perlmutter, Grain Brain and Wheat Belly, but I found that the gluten sensitivity might be one level, but all of us have allergies to the excessive phytochemicals we're putting in our body, and the gut is the #1 source for them to get in our body, and where it causes cancer, all the immune diseases. It causes all autoimmune conditions, and it causes infertility for men and women. And Dr. Fox down in Jacksonville has worked a little bit on the PCO diet, but dietdoctor.com has some really great stuff. And if you really want to jump into it, I recommend go full force.
Absolutely. Do you have a lot of patients who suffer from secondary infertility? And in general, how do they respond to treatment compared to primary infertility patients?
So primary infertility, in my explanation, is you've never been pregnant at all. It's actually, you've been pregnant, but you even could have had miscarriage. So secondary is you've been pregnant and you might have had miscarriages. I consider secondary that you've had a child and now suddenly you can't get pregnant and or you're miscarrying. And so I'm finding they're really not different, they're the same. I believe in some way that first conception may actually have some foreign antigen antibody interactions in your body that may actually create that. But we're all cars. As cars age, more inflammation, more reactive oxygen species happen, and so it's the same problems. And you need to really search it in a very methodical, straightforward. Look at the sperm, look at the tubes, look at the immune system, and look at the hysterosalpingograms, and then consider the laparoscopy. In general, the secondaries may be a little bit easier in some cases, but really, if you have either one of those, I don't even like to use that as a definition at all, primary and secondary. So I like to leave it out of the vocabulary. The infertility is really an immunologic condition, inflammation, and you either have sperm or not, you have eggs or not, you have open tubes or not, but even with or without those, you want to approach it in a very similar fashion.
Absolutely. The next client will be traveling to us from Michigan, and she's very nervous about traveling to a clinic outside of the state. Any words of advice to make her feel better about traveling to us?
Talk online and ask those clients that have traveled here. And I traveled all the way from Los Angeles to upstate New York, and it's amazing. We see people from Spain, Australia, England. I mean, we're in this human family, and it really is the same conversation, whether we're talking to you on the camera or you're just listening in. We do a lot of Skype and FaceTime or just chit-chatting on the phone. We want to make you feel at home. And I believe that we have great places to stay, and we have a great spa experience. So bring your spa attire, and I think that give us a call, look at our website carefully, talk to other people online. What was their experience? And definitely, if anyone has had an experience that didn't feel right, we want to learn and make sure we're doing the best we can every single day, but there's always that area of improvement. But I love this area, and I'm from LA, the crowded city. This is an amazing, low stress, open spaces, no traffic, lower cost. But one thing is that we've learned in our destination health and wellness is CNY Fertility, because we not only deal with infertility, but we deal with all aspects of health and wellness, that simply handling those other areas. And at our wellness center, many clients come here that do not have infertility, but are seeking other improvements in their health and wellness. And we've been amazed through light therapy or vibrational therapy or healing oils or fragrance or massage and yoga and acupuncture. So many of those things happen. So right now we're actually working on our new destination resort in a sense, but we still want to make sure it's affordable and accessible with high quality that makes you feel at home.
Absolutely. So next client is wondering how important it is to have the saline infused sonogram. I've had the HSG and plan on IVF.
Well, saline sonogram, where you inject the saline into the uterine cavity and then do an ultrasound at the same time, it allows us to adequately, in a reasonably way, to look at the uterine cavity and eliminate polyps or fibroids or most scar tissue. It's not the gold standard the hysteroscopy is. It's not absolutely necessary, but if you want to do as many things as you can, the saline sonogram is that next level to make sure the cavity is an improved environment to reduce the chances that something abnormal is there. So it's easy enough. We actually combine it in our facilities along with the catheter and injecting the fluid with the hysterosalpingogram and taking the fluoroscopy. We do an ultrasound at the same time and can look in the cavity. I definitely think that even doing a hysteroscopy is that next level, that if things haven't worked before, add that.
Absolutely. Is the endometrial biopsy or an endometrial scratch an additional cost? Is this something I should suggest in a way ahead of time? And will we do the embryo glue at the same time as the endometrial scratch, or is it either or?
Well, the endometrial scratch is a uterine biopsy or a hysteroscopy D&C cleaning out the uterus. In the week prior to your menstrual cycle, or while you're on the Lupron prior to starting the estrogen before a frozen embryo transfer. In some cases, we still might even do it while on the estrogen, but early in the cycle. It's interesting how we don't do these things for everyone, and then you wonder, oh, well, maybe we should do everything for everyone. Is it really necessary? It does add a little bit of cost, a little bit of discomfort, and sticking something in the uterus comes with a little bit of risk. I believe it's really low, and so I would say that ask about it. It's something that's on our menu list, but just like intralipids and this food plan and IVIG aren't on our standard list, we're beginning to make it more and more, hey, let's make sure we're treating all aspects of your potential issues in order to maximize your one time. But we want to make sure we're communicating an option, and some people say, you know what, I want to start small, a few things. If this doesn't work, then I'm ready. And the one thing I know is persistence on the path and changing it up is important. Trying to understand that maybe it really doesn't take all these things, and then say in so many cases it doesn't. So, but if we're talking about it, obviously, ask about it, and we want to make sure that it's an offering.
So after 2 missed miscarriages and 2 chemical pregnancies over 2 different IVF cycles, what advice can you give to someone to sustain a pregnancy?
Well, this is the biggest challenge. Is it an egg or a sperm issue that creates an embryo abnormality? So don't forget the guy and all the antioxidants and looking for a varicocele, possibly adding HCG and Clomid, definitely the healing arts and anti-inflammation. Same in the woman. But those losses, in my mind, is either look for more adverse conditions of autoimmune diseases, look for thyroid dysfunction, look for lupus, but since we know most of it is immune, empiric treatment is not unreasonable. Since IVF is really an empiric therapy for so many people, open tubes, normal sperm, not getting pregnant, we do IVF, which is far more costly than the immune treatments. Weekly to every 2 weeks of intralipids, definitely in that case. IVIG, a dose 2 or 3. Now you want to consider definitely adding Neupogen, Humira, Prograf, and then the laparoscopy, hysteroscopy looking for endometriosis, and the 7 to 14 to 28 day of antibiotic therapy, empirically, maybe that next way to really go. And then PGS, pre-implantation genetic screening, where we biopsy the embryos and freeze them at the blast stage. and identify, is there a chromosomal aneuploidy in that embryo that may be explaining that. I believe that in some cases there's mosaicism, where that embryo may show up abnormal on the biopsy, but it's normal, or vice versa. So we're cognizant. I believe the only way to know if an embryo is going to make it or not is to put it in the uterus. And under some cases, you might look towards a gestational carrier in order to solve your problem. We got to be open to all these opportunities. And then sometimes we're even looking towards donor egg, donor sperm, or donor embryos in order to help make that happen. And we're putting the message out there. If you have anyone that's interested in donating eggs or sperm, where we can build our egg and sperm bank and offer those eggs and sperm at a lower cost, we're looking to build that egg and sperm bank to make it more affordable for everyone. And then the other is donate embryos. Help someone else create life. That's really such an important component to that.